All right, welcome back to the podcast. I am joined today with Dr. Michael Cummings. We have no conflicts of interest. He has been a regular person that comes on the podcast that people appreciate. Pretty much every week, I get a nice letter thanking Dr. Cummings for coming on and his wisdom and sharing that with all of us. So, Dr. Cummings, thanks for coming on.
Oh, I'm happy to be back and always pleased to participate.
So, today we're going to be talking about substance use disorders. We're going to start with alcohol and then maybe go to opiates, see if we have enough time. This is going to be acceptable for the new DEA CME update. So starting in the end of, I think, June of 2023, if you're listening to this in the future, the DEA says now that you need 8 units of substance use CME and for the treatment and management of patients with opiate and other substance use disorders, including the appropriate clinical use of all drugs approved by the FDA for the treatment of substance use disorders. So we'll start with alcohol today. Dr. Cummings, do you want to talk about maybe, I think we always start with like the history. We want to talk about
Yes.
the history of substance use, specifically alcohol and the treatment.
Well, certainly alcohol is mankind's, I think, probably oldest substance of abuse. It has been used literally for millennia. Um, Probably discovered at some point in prehistory, the first time somebody let fruit juice uh, ferment and discovered that its properties had changed. It remains, despite all of the other epidemics in drug abuse and substance use that have occurred, alcohol remains the most widely consumed uh, intoxicant by human beings. It's estimated that roughly 55% of the US population drinks on a regular basis. Um, Certainly not all of them problematically, but a fair portion problematically, at least at times. Um, so that it has become and has been an ongoing issue for medicine for quite some time, and certainly has been a major component of substance use disorder treatment in the US, albeit it started more with the 12-step programs than with medicine, and made its way into medicine and psychiatry in terms of treatment um, over the last 50, 60 years, um, which brings us to where we are today, with alcohol often being the first mind-altering substance that people experiment with in early adolescence or late childhood. And for most people, it doesn't get them in trouble. They experiment, they may become intoxicated a few times, but they move on. A small number of people, however, do become addicted to alcohol and begin to use it problematically. And indeed, it is estimated that it costs in the US roughly $249 billion a year in terms of both medical care and lost productivity. So it's socially not an inexpensive substance.
Wow. Always amazed at how you pull this right out of your mind and synthesize it. It's like chat GPT Cummings, but it's maybe
Well,
like
perhaps
a
one of these
version.
days I'll become an AI. I don't know.
Yeah, I'm sure these episodes will create a AI Cummings in the future. Not that I will produce that, but someone will use the data sets, right? No, it's a joke. Okay. So, okay, what types of people are prone to kind of go from you know, occasional use to problematic use?
Um, it does have a fairly strong genetic component. It's estimated that about 50%, maybe a little bit more of the risk is related to um, the genetics of the individual. That's been demonstrated in looking at families, including adoption studies, where they looked at risk of becoming addicted to alcohol. Um, I worked with Mark Schuckett at UC San Diego for a period of time, and indeed, this was his area of study. And he found that in adopted away children, that is, adopted away at birth from families that included at least one individual who was alcohol dependent, those children, even though they were reared in a non-alcohol using home, uh, had roughly a four-fold greater risk of having difficulty with alcohol once they were exposed to it than people who came from families who had no history of people who got into trouble with alcohol, suggesting a fairly prominent genetic component. The other element he found was that in terms of phenotypic characteristic, those who had the least response to the effects of alcohol, that is, it took them more to become intoxicated, were at highest risk.
Hmm.
So that if they did drink, they had to drink more in order to experience the effects, and the effects wore off more quickly. Um, so that they were in essence kind of motivated to drink more than their compatriots, um, which I know he was certainly strongly an advocate of in dealing with families that had familial history of substance use disorder involving alcohol, of doing early genetic counseling, basically along the lines of telling children and early teens, almost everyone during adolescence tries alcohol. Most of your friends will try it. Nothing too bad will happen. They'll kind of get over it and move on. But for you, it may be very different. It may be the first time that you kind of feel completely normal, because one of the psychological characteristics he also identified in people prone to substance use disorders was that their baseline was somewhat anhedonic. They were not able to enjoy the um, simpler pleasures of life as well as other people did. But when they came across alcohol or other substances, that was often the first time that they felt completely normal. And that was in part what hooked them so strongly into using the substance and wanting to repeat that experience, which eventually that becomes a jumping off point for the underlying neurocircuitry of addiction and the reward pathways in the brain.
Okay, before we get there, any epigenetic findings with alcohol use?
Yes, most of the epigenetic findings have come from, as you might guess, animal studies. And indeed, you can create uh, rats who are prone to alcohol dependence by only letting those who like alcohol breed. And in about 2 or 3 generations, you can create a colony of rats who are very prone to become alcohol dependent. And in looking at their genetics, there are some promoter genes that are created and some microRNA variants that are created in those rats that appear to make their offspring more likely to consume alcohol than even their parents were. So yes, there are epigenetic connections in terms of risk for alcohol dependence. They're not all that well understood, and certainly not in human beings at this point. Many of them have to do with cell adhesion. Some have to do with how easily one of the key molecules involved in addiction, delta phos B, which is generated in the spiny neurons of the nucleus accumbens, people who are very prone to make that particular promoter agent for DNA replication are more vulnerable to becoming addicted.
That's fascinating. And so, let's talk about the neurological circuits. What have we found?
Okay. Yeah, this is actually a pathway that we understand fairly well. Uh, I usually like to start with the normal physiology. Why do we have whatever it is we're talking about? The ventral tegmentum contains a number of dopamine generating nuclei. Some of those impinge on a nucleus called the nucleus accumbens. It has two parts. It has a core, which is mostly concerned with motor activation, and a shell that is basically generates stimulation of reward. Its normal function is to motivate us to pursue salient goals such as food and water and other things that we need. Motivates us basically. In some people, though, those people who are genetically prone, exposure to substances, including alcohol, can serve to um, get them addicted to the substance. And we know this is a key element because in animals, if you ablate the nucleus accumbens, if you do that in those rats we were speaking of that were very prone to addiction, they become absolutely resistant to addiction. You can't get them addicted to anything. You can't do that, of course, to a human being because you'd also be creating a completely anhedonic person. The projections from the nucleus accumbens include the prefrontal cortex, the orbital cortex, the cingulate gyrus in the forebrain, and then also there are a number of projections to the amygdala and hippocampus, so that this basically, when you come across something that is inherently rewarding, it reinforces you're seeking whatever that was, be it alcohol or a more appropriate target. It also gets embedded in memory, and in the case of addictive substances, when the person uses the substance repeatedly, it alters the functioning of the reward circuit, the reward pathway, so that the person becomes driven to be more and more and more focused on obtaining and using the substance at the expense of drives toward more positive things. And they also become less sensitive to aversive outcomes, which is why a lot of people with addictions, they get to the point where they're only focused on getting the next hit, getting the next drink, and sort of job and family and responsibilities go out the window. And that's related very directly to changes in the what are called the D1 medium spiny neurons of the nucleus accumbens, and how they change in response to whatever the addictive substance or activity is. They shift literally in terms of their DNA expression so that they indeed make more of delta phos B, which in turn turns on a bunch of genes that activate the nucleus accumbens more than it should be. um, and drive it toward this increased seeking of the addictive substance and ignoring of everything else. It also, because of the attachment to memory via the hippocampus, um, comes to be that the person is as much driven by anticipation of use as by the use itself, to the point that at some point, the person's addictive behavior goes from being sort of a choice to being more compelled or compulsive behavior.
Hmm. Wow. That's next level fascinating to me. It's like there's this shift there, especially the move towards like averse things are not as aversive.
Mm-hmm.
And I've seen that often, but it's
Yeah,
really interesting.
if you think about all of the truly awful things that happen to people as a result of their addictions, I mean, certainly with alcohol addiction, for example, people's health deteriorates. They die much sooner than if they were not alcohol dependent. They often lose family and income and, all of the things that most people enjoy and seek and work for. And despite all of those things, they continue to pursue the substance.
Okay, so a lot of those things that you just talked about, the changes, is that just with alcohol or is that going on with other addictions as well?
It goes on with other addictions as well. In fact, I think one of the things we've discovered is that regardless of the initial mechanism of intoxication of a substance or an activity, it's not limited to substances. Um, the reward pathway, these circuits, essentially drive all of the addictions.
Mm.
If it doesn't change the way the reward circuitry works, doesn't change the nucleus accumbens, it's not addictive. And in many ways, while substances are probably the most rapid thing that people can become addicted to, DSM recognizes things like problematic gambling, and at least entertained the idea of looking at internet addiction. It does recognize sexual addiction. Um, and if you look at what underlies those, all of them come down to the same neural circuitry.
So the neurocircuitry as in like nucleus accumbens
Yep. The
and all the
nucleus accumbens and its projections
and its projections.
to both the forebrain and to the temporal lobe in terms of the basolateral amygdala and the hippocampus.
Okay. And what about the frontal lobe? Does it go there too?
Yeah, the
You
frontal
mentioned that
lobe,
earlier.
particularly the prefrontal medial cortex and the orbital cortex, um, that's part of what then helps drive the person to anticipate the next use of the substance, or also makes people sensitive to environmental cues that are related to the substance. If you, um, again, with an animal model, uh, monitor dopamine release in the ventral tegmentum. Dopamine is the major stimulator of the nucleus accumbens, with enkephalins being a second source of stimulation. If you take a rat that has become addicted and you simply put it in the environment where it usually gets alcohol, um, you'll see those neurons fire as much or more than if the animal actually had alcohol present. Um, and,
Oh,
if you talk with somebody who is alcohol dependent, often for them going into an environment where alcohol is served, for example, a bar, it sets off a whole chain of responses that very much mimic the intake of alcohol itself. It's one of the reasons that environment and cues are so
mm.
so much risk factors for people who are vulnerable to addiction.
Yeah, I think psychologically what I've found is that the moment that the person that decides they're going to drink, like let's say they're an alcoholic who hasn't had a drink for a while, they're driving home. The moment that they decide that they're going to drink, they just calm down and they just like they already are having that euphoria. Uh,
Yes, yeah. And there have been some animal studies where they have found that indeed the activation of the dopamine neurons of the ventral tegmentum actually is bigger for the anticipation than it is for the actual obtaining and using of alcohol or other substances. Basically, those dopamine neurons can fire in two ways. They can fire tonically, which is sort of a slow, steady pattern, or they can upshift to a phasic release where they literally release a flood of dopamine, which in this case, the nucleus accumbens has um, D2, D3, and D4 dopamine receptors. When they're flooded with dopamine, it basically activates the nucleus accumbens. The nucleus accumbens, the shell also responds to enkephalins or opiates if you're talking about taking an opioid. Um, the mu receptors tend to produce a euphoric response. The delta receptors reinforce the seeking of the stimulus, which, if you look at how addictive substances are, those that are most quickly addictive are those that directly increase dopamine or which are themselves opioid agonists.
hmm.
Uh, the other drugs of abuse get there indirectly, and usually it takes longer to become addicted to them.
Yeah. Any other things you wanted to discuss before we get into the medications that the FDA has approved for this?
Um, I think the important thing is, for a long time, people who were prone to addiction, because, well, frankly, because of some of the behavior that results, were looked at principally as being characterologically flawed. Um, I think the discovery and the description of the genetics and the underlying neuropathology points out that these are indeed chronic relapsing diseases, that, these people are psychiatrically ill because of their vulnerability to, either an addictive behavior or an addictive substance.
Yeah, I think I think that can decrease the shame a lot for the treatment and
Yes.
the family maybe having some like, okay, this person has a disease. There's a biological aspect to this. It's not a moral failing. That's what you're saying, right?
Yeah. I mean, the person still bears responsibility, just as, for example, somebody with diabetes, they have a disease, but they're still responsible for managing their diabetes and not passing out on the freeway and, causing death and mayhem. The same thing is true of somebody who's a substance addicted person. They still are responsible for how they handle their addiction, but they're not responsible for the fact that they have an addiction. That was a product of their genetics and environment.
Good. Yeah. Okay. So let's go one by one through the meds. Disulfiram, first
Okay.
medication.
Yeah, disulfiram, which is not used very much anymore, is an inhibitor of alcohol dehydrogenase. Alcohol is metabolized from alcohol to acetaldehyde to eventually acetyl-CoA and water. If you inhibit alcohol dehydrogenase, you get a huge buildup in the acetaldehyde. Acetaldehyde is a fairly toxic molecule. It's what is responsible for the signs and symptoms that people have when they say they have a hangover. The headache, muscle aches, um, feelings of dizziness, nausea, vomiting, sometimes diarrhea. Um, if somebody takes disulfiram and then they drink alcohol, they are giving themselves essentially an enhanced or magnified uh, alcohol-induced hangover, which the idea was that if the person knows that's going to happen, it will help them resist drinking alcohol. Um, the, you know, this and the other medications we'll discuss, if somebody is dedicated to drinking, that is, they're still in what is termed by the addictionologists the pre-contemplative phase of the illness, frankly, the medications are not going to help very much. If you have, however, somebody who is attempting to become sober, establish their sobriety, but they're struggling, their nucleus accumbens is pulling in a different direction than they're wanting to go. Things like disulfiram can uh, help them in terms of saying, well, if I do that, it's going to be awful. And maybe if they've done it once or twice, it's a very potently adverse conditioning response, um, so that they can indeed begin to associate the alcohol itself with a very negative outcome.
Mm.
It is potentially dangerous if you drink a lot of alcohol with disulfiram. It can produce uh, a lethal outcome, um, which is
Oh,
something that, of course, we have to educate patients about. That if you drink 5, 6, 7, 8 drinks with disulfiram on board, it can become medically dangerous.
hmm. And how long um after your last drink can you take disulfiram without getting sick with the last drink?
Uh, Usually the advice is that you should wait at least 24 hours in order to basically allow the alcohol in your system to be metabolized, and then start the disulfiram. The effects of the disulfiram are entirely dependent on how much alcohol is present when the drug is taken. Onset of action for disulfiram is relatively fast, over 1 to 2 hours. So you want to be sure the person's alcohol level is either at zero or approaching zero at the point where they start the disulfiram. Of course, that depends on how much they were drinking. Alcohol is cleared by zero order kinetics, meaning, unlike most things that are cleared um, at a percentage of their concentration, alcohol is pretty much cleared at a rate of 1 drink per hour.
Hmm.
So if the person was drinking, uh, 6 drinks an hour and then they stop, it's going to take about 6 hours for that alcohol to be metabolized. Um, yeah, so
Oh,
it's a fairly linear relationship.
so it's not like half-lifing like some other things.
No, it's unusual in that alcohol is cleared via zero order kinetics rather than being proportionate to the concentration.
Yeah.
Basically, you clear alcohol at about 0.02% per hour,
Right.
if you're
Yeah.
an average metabolizer. Now, if you've been drinking enough that you have liver damage, it may well be slower than that.
Mhm.
Um, um, to give people an idea, in order to reach the legal limit for being intoxicated, which in California is 0.8, I'm sorry, 0.08%, um, alcohol content in the blood, that for an average sized man is roughly 6 drinks in an hour. For a woman, it's roughly 5 drinks in an hour. A drink being an ounce and a half of distilled liquor that is 80 proof, 6 ounces of wine, or 12 ounces of beer.
Okay, and then disulfiram lasts like the half-life is like 7 hours or so.
Yes,
So how long after the
day and a
last
half, 30,
dose?
35 hours, it will be gone. There is a slight tail, uh, not much of one though, beyond the drug. Uh, it takes the enzyme a little time to recover after the drug is gone. And then the person's clearance of alcohol will return to their baseline. Um, Different ethnic groups do differ quite a bit in terms of how much alcohol dehydrogenase they have. Northern Europeans, um, Celts, etc., English have quite a bit of alcohol dehydrogenase. A number of Asian groups may have very little inherently. Although if people drink routinely, their alcohol dehydrogenase will increase because the body is attempting essentially to get better at metabolizing alcohol.
Yeah, that's good. Okay, let's go on to the next one. Or I'll say one thing on just my use of disulfiram. The patient has to be motivated. They have to be willing to take it, obviously. Usually the best patients are the ones that, maybe in the morning they they feel a lot more clarity with their desire to quit. And then in the evening, there's a lot more temptation or desire
Mm-hmm.
to quit. And so they're willing to take it in the morning because they want to quit. And then they're not as like tempted to use it later on. So those tend to be the ones that I find are it's useful for. Um, shall we talk about naltrexone?
Yes, naltrexone is, of course, an opioid antagonist. It binds to and blocks opiate receptors, which that nevertheless applies to a variety of things. Naltrexone has been shown to decrease number of drinking days, has been shown to decrease the craving for alcohol. Interestingly, it also decreases the craving for amphetamines and even for some behaviors like kleptomania. And in part, what you're looking at is that, as you may recall, we said in the nucleus accumbens that the mu receptor and the delta receptor, both opiate receptors, are involved in driving the addiction or driving the reward. If those are blocked, which naltrexone will do, it makes the behavior or the substance, including alcohol, less rewarding, um, and therefore it is not craved as much, or it's easier to resist the cravings. Which is why this drug, just like disulfiram, is most useful for those people who have decided they want to quit, but they are struggling with their own cravings. The nice thing with naltrexone is it's otherwise a fairly benign drug. It has some risk of post-dose nausea, which can be overcome by taking it with food. Dose range is 25 to 150 milligrams a day, although it is rarely used above 100 milligrams because at that point, um, you've blocked every opiate receptor the person has. So I'm not sure what the purpose would be of going higher. Um, the oral is a once a day drug. It does come also, though, in a long acting injectable, which can be very useful for people who are going to be in difficult or tempting environments. Um, it's a once a month injection of 380 milligrams that's then slowly absorbed. Um, the drawbacks of taking naltrexone are that should you need an opiate analgesic for acute pain, you break a leg or something similar, it's going to be very difficult to control the pain with an opiate analgesic because you're taking a drug that blocks um, the receptors that modulate pain sensation as well.
What do you think about like intermittent naltrexone use compared to daily naltrexone use?
Most of the studies suggest that the daily use is better. Um, and that may well be because the more consistently the person can stay away from their um, substance of abuse over time, the essentially the more the nucleus accumbens moves back toward its normal physiologic state. The molecule that we mentioned earlier, the delta phos B, uh, once it's produced in the cells of the nucleus accumbens, it has two phosphorylated forms, and it then lasts for a month or two. And you're to get away from the addiction, you're wanting the levels of that molecule to fall, so it takes time.
So the long acting one, how does it
Mm-hmm.
like? What's your preference for long acting versus the short acting one?
It depends on the setting. If the person is in a setting where they will fairly clearly, reliably take the oral medication, say, for example, in a hospital setting, or in a setting where family can monitor their intake, um, the oral will work just fine. If they're going to be in a setting where they may be tempted particularly to skip the naltrexone, um, then the long-acting injectable is highly desirable for many of the same reasons that long-acting injectable medications of all kinds are desirable. It gets adherence off the table. You clearly know if somebody takes an injection once a month, um, and once it's in the muscle, you know, there's no way to avoid it for at least the next month.
All right. How about acamprosate?
Acamprosate also works at the level of the nucleus accumbens. It blunts some of the changes caused by alcohol, that is the upregulation of the activity of the nucleus accumbens. Um, it's in some ways a difficult drug for a lot of people because it's a TID dosing schedule. We have to take it 3 times a day. It's 666 milligrams, both acutely and for maintenance, 3 times a day. And obviously, for any drug, the more times a day you have to dose it, the harder it is to be adherent to it. Um, just because it's hard to remember, well, did I take it or didn't I? Or it means having to take the medication with you to be sure that you have it. Um, it the only other real caveat with it is it does depend on the kidneys for clearance. So you have to reduce the dose by about half if the person has an estimated GFR of less than 50 milliliters per minute. Um, some people find it very useful because it doesn't otherwise have much in the way of side effects. Some people do complain it makes them feel somewhat anhedonic, but it's not clear whether that's actually an effect of the medication or the fact that they're just not drinking. If you talk with long-term alcohol dependent people who become sober and maintain their sobriety, most of them will acknowledge that part of the price they pay for their sobriety is kind of a mild chronic anhedonia.
Yeah. What okay, for the naltrexone, That's one of the things that I've always been curious about. Like, does it reduce pleasure in other domains along with like the pleasure with alcohol?
It does. It also does increase proneness to physical discomfort to some extent. Most of us have minor aches and pains that our endogenous enkephalin system handles, and you're largely taking that system offline with a drug like naltrexone. So little aches and pains that you might not have noticed before are suddenly more noticeable.
Okay, let's say someone is um, using a lot of alcohol and they come in for detox. What are the common medications that are used to detox?
To detox them, well, first off, people are often dehydrated because um, alcohol decreases the release of antidiuretic hormones. So if they've been drinking chronically, despite the fact that alcoholic beverages include water, they're on balance, they're tending toward negative water balance. So they'll be dehydrated. They're often thiamine deficient, which an important element is to give them thiamine, so that if you then begin to refeed them um, with dextrose or with food, you don't wind up causing them to have, um, in the long run, either Wernicke's encephalopathy or Korsakoff psychosis. And of course, the other thing that you worry about acutely in somebody who has been drinking heavily is acute alcohol withdrawal up to and including delirium tremens, which has a fairly high mortality rate. Because when the person stops drinking, all of the stimulatory systems, particularly their noradrenergic system, which is upregulated to counterbalance the sedative effects of the alcohol, those systems are now unopposed. So the person literally starts to tear themselves apart. They become tachypnic, tachycardic, develop coarse tremor, um, often visual hallucinations. They may have seizures and become delirious. There are a number of things you can do for them. They often get vitamins, including thiamine IV, along with magnesium to increase their seizure threshold. Of course, you hydrate them. Once they've had thiamine, then you can give them dextrose because they're or other nutrients because they're often malnourished as well. And we're talking here about the heavy duty alcohol dependent person. The other thing, of course, you have to do is decide how you're going to treat their alcohol withdrawal. The most traditional method for doing that has been to give them a cross-tolerant medication, um, most often lorazepam, and to then gradually taper it over about 5 days so that you eliminate the withdrawal from the alcohol. I think what a lot of people don't appreciate is how much lorazepam it may take to balance their alcohol intake. Um, for truly heavy drinkers, um, it your initial dose may be 4 to 6 milligrams of lorazepam. And the way to do it correctly is to give them a dose, look at them after an hour. If they are now calm and a little bit drowsy, but easily wake up and talk with you, that's the state you're aiming to maintain. If they're still shaking and still delirious, then you give them another dose, come back in another hour. At the end of 24 hours, you know how much it took, and then you can stair step that down by about 10 to 20% per day.
Hmm.
Um, People also have used anti-epileptics for the purpose of controlling alcohol withdrawal, and that's included drugs like valproic acid um, and other
GABA.
leveracetam and other anti-epileptics. The risk with them is you may not control some aspects of the withdrawal, despite the fact that you're making the person not have seizures.
What do you think about gabapentin for
Uh,
benzodiazepine?
Gabapentin for if it is a milder withdrawal, that is somebody who is having alcohol withdrawal symptoms, but they're not somebody who's at risk of delirium tremens, then gabapentin may work well. You could also use pregabalin or tigabine. Any of the GABAergic anti-epileptics will work. Um, One way you can tell how severe the withdrawal is going to be is when the person presents, ask them how long it's been since their last drink. If you have somebody who says, well, I was drinking 8 drinks an hour and I slowed down to 5 drinks an hour and I started shaking, that person is going to have a very bad withdrawal because a very small relative decrease was enough to tip them into withdrawal signs and symptoms. On the other hand, if somebody says, well, I've been drinking too much, but I had my last drink yesterday, and the only thing I notice is I feel a little achy and I have a slight tremor, that person is not going to need a lot of support to not have a severe withdrawal.
Any other clinical pearls on detoxing someone effectively?
I think the key element is to appreciate how tolerant the person may have become. Uh, Back when Librium, chlordiazepoxide, was the popular drug for alcohol withdrawal, I've seen people write orders of 25 milligrams Q 6 hours PRN alcohol withdrawal. And they would be writing this for somebody who's been drinking 1 or 2/5 of whiskey a day, not realizing that 25 milligrams of chlordiazepoxide is roughly equivalent to 1 drink. So they were they were expecting an awful lot out of a very tiny amount of sedative hypnotic.
I think those are some really nice pearls. I think the Wernicke's encephalopathy is something I think it's under thought of a lot. So what would be like a quick assessment on someone to kind of think through if they need some high dose thiamine, and how much thiamine would you give?
Typically, if you're giving them IV vitamins, banana bag, typically called because it's yellow. Usually you want to be sure they get at least 100 milligrams of thiamine in that. Because and it's the thiamine deficiency that causes the Wernicke's encephalopathy. It's not a direct effect of the alcohol. It's the fact that alcoholic beverages do not contain thiamine, and frequently for somebody who's a severe alcoholic, they often have essentially stopped eating. They're getting all of their calories from the alcohol that they're consuming. So they become thiamine deficient, and um, thiamine is a necessary cofactor for energy metabolism in neurons. So literally, their neurons become ill and will start to die. They appear confused, disoriented, and probably the hallmark is they often present with a very coarse lateral nystagmus all the way up to dysconjugate gaze. Um, so in somebody who's been drinking a lot, they come in with signs and symptoms of confusion and um, abnormal eye movements, that person is at the top of the list to get thiamine as soon as you can lay your hands on it. Another pearl that goes with that is do not give them any dextrose before giving them the thiamine, because all the dextrose will do without thiamine present is increase the metabolic burden on the neurons. So you'll wind up killing off neurons faster unless they already have the thiamine on board.
Classic board question there, guys. No
Mm-hmm.
dextrose before thiamine. Also, I think that people underdose, like when they do catch it, they underdose like you need like 400 milligrams IV 3 or 4 times a day. Any thought on like how you would dose it, or do you think 100 is enough?
100 may be enough for the initial dose, but basically you want to be very generous. Thiamine, if you give them too much, nothing bad will happen. If you don't give them enough, they may go from having Wernicke's encephalopathy to Korsakoff's psychosis, or more appropriately, it's Korsakoff's dementia. So many of their neurons will die that their brain is not going to recover. Thiamine is cheap, and it's not a fat soluble vitamin, so anything in excess that you give will be eliminated. 400 milligrams 3 or 4 times a day is just fine.
Excellent. Let's see. Any other? Oh, I guess we could talk a little bit about, you know, interventions. How effective are interventions in your mind?
Well, they can be very effective. Everything from motivational interviewing to um, having family and friends and people important to this individual intervene and try to get them into treatment. Because although we've talked primarily about medications used to treat alcohol use disorder, the truth is, unless the person is also plugged into a treatment program for their alcohol dependence, the medications alone are essentially doomed to fail. It needs to be a combination of active participation in a treatment program, and where needed to help curb craving, medications to assist the person.
Okay, so yeah, obviously it's really going to be a combination of being in a treatment program, lots of good psychotherapy and medications. Um, Go ahead.
Yeah, people. There have been a number of psychotherapies devoted to treating substance use disorders and alcohol dependence. Of course, the original were the 12-step programs. Cognitive behavioral therapy has also become very popular in treating substance use disorders to help the person overcome some of the distortions in their thinking that occur as they get more and more involved in the substance and related behaviors. Um, Having a support community, whether that's other addicted individuals who can help the person, or family and friends who can provide a support network, all of those things are critically important as to whether the person will be successful in obtaining and maintaining their sobriety. I think another element of this is to recognize that the substance use disorders, including alcohol use disorder, are by their very nature chronic relapsing diseases. So if the person does slip and they drink, that's not the point at which you say, oh, it's hopeless, we're just going to forget you. Because everyone is basically going to slip at some point.
Yeah, you kind of have to be in it for the long haul if you want to treat this population and
Yeah.
uh, like
I
Will
mean, it
is.
wouldn't make any more sense to abandon the patient if they slip than it would be to tell a diabetic, well, if you eat a candy bar and your blood sugar is over 200, that's the end of your treatment.
Or if you have a depressive episode, that's the end of your treatment of depression.
Yeah.
You know?
I mean that's not a very good model for chronic recurring disease.
Yeah. I heard oh gosh, this one psychiatrist was like, I discharge my patients when they're admitted to a psychiatric hospital. It's like, what? I remember hearing that one time. I was like, that's the worst idea ever. Like, why would you do that? That's when they need the help the most, you know?
Yes, exactly. Um,
Yeah.
and I think that's part of the psychoeducation for both the patient and frankly for the others in their life, is that this is a chronic relapsing illness by its nature, and the goal is to get them sober and to minimize the relapses, both in terms of frequency and the amount of damage that gets done. But, you know, forewarn the person that the end of the line is not, oh, you have one drink, it's all over. No, it's one drink, we need to get things back under control.
Yeah. One of the other sort of lessons I learned in treating this population is if they're on topiramate, topiramate can be very powerful in keeping someone with like less drive to use alcohol. I don't know. How would you say it?
Yeah, basically, topiramate's an interesting anti-epileptic. Of course, uh, people have suspected that the mechanisms by which it decreases appetite, that is by altering the balance and activity of the feeding and satiety centers in the hypothalamus, may also have in part to do with how it alters um, craving for substances. Um, because certainly the craving for an addictive substances is not entirely unrelated to, cravings that people have, for example, for food. Because we didn't talk about it before this, but the nucleus accumbens is also, of course, connected to things like seeking food and water and shelter, those salient goals. So it's not surprising that if you can suppress appetite with a drug like topiramate, it's also likely to have some effect on people who have an addiction. And indeed, it decreases impulsivity in some people as well, likely by affecting some of the very same circuits.
Yeah. So I had a patient once who were trying to lower their meds in general, and this one in particular, and they had a history of pretty bad use disorder. And when we started going down on it, they started craving like hardcore. And I was like, oh, that's what that one was doing and why it was put on there, you know, because sometimes you see a huge dose of topiramate and you're like, okay, is this causing more side effects than it's causing good? Um, yeah. Are there any other drugs that are kind of off label that are often used for alcohol use disorder that you want to mention?
Probably, I think we have covered the major ones. Probably the one that is most used off label is naltrexone these days,
Yeah.
because uh, for most people, it's a fairly well tolerated medication that is actually pretty effective at reducing the number of drinking days. Most of the studies out there suggest that people who take naltrexone and have cravings will have about a 2/3 reduction in the number of days that they drink.
Um, okay. Well, I think this is nearing the end here. And I think we're going to keep this to alcohol. And next time, maybe we'll go through
Yes.
opioids and opiate use disorder.
Yeah, certainly a relevant topic given that we're still in the midst of an opioid epidemic, especially with the introduction of fentanyl, which we can discuss at length.
Yeah, I actually did an episode on fentanyl in 2019,
Hmm.
um, predicting that it was going to be absolutely devastating.
And it has
It
been.
it already was. It already was. But I only saw it getting worse because of the cheapness, because of
Hmm.
what I was seeing in the addiction units. It covered detox unit, and the patients would be finding it in all sorts of things not fentanyl related. So it'd be like when they would get meth or cocaine, it would be cut with some fentanyl,
Hmm.
or fentanyl would be added to it.
Yes. And that certainly has continued to expand. Many of the drug cartels have now begun introducing it into some prescription medications that are being illicitly produced. Um,
Mm-hmm.
Although likely that's not by design, likely that's just because of very sloppy manufacturing.
Yeah, so it's like there was a I guess I don't know, someone who knew someone in the area that we both live who had their own pill making machine,
Hmm.
and he said they would put just a slurry of medications in and make it look like an oxy or make it look like an Adderall. And I've had
Hmm.
a number of patients that got addicted to Adderall, street Adderall, because they couldn't get regular Adderall or whatnot.
Hmm.
And the types of symptoms that they were having were far beyond what Adderall would cause. So it's just good to know that whenever you get something off the street, you may not be getting what you think you're getting nowadays.
Right. Well, a very long time ago, UCLA did a study where they had people bring in what they had bought on the street, and they would give them a number so they could call back anonymously, and the UCLA lab would analyze what was in the what they had bought, a portion of it. And when they called back, they would ask the person, "Well, what did you think you bought?" What they bought and what they had were matched in only 1 out of 13 cases
Hmm. Yeah.
because
It's,
drug dealers are not heavily into quality control.
no, it's like, do you want to trust your drug dealer to dose fentanyl properly when like literally a couple grains of it can kill you?
Well, especially these days, I think the latest thing I've come across on the street is combination of the large animal tranquilizer xylazine mixed with fentanyl,
Hmm. Wonderful.
um, which is an incredibly dangerous combination in terms
Yikes.
of your odds of dying are fairly high.
Okay. More more next time on this fascinating deadly combination.
Yes.
Um, yeah, thank you so much, Dr. Cummings, for coming on. And we'll leave it there for
Okay.
today.
Thank you.